get an opportunity to work with a patient like this, they really, I mean, anything you can do to get their pain level down, you've really accomplished a lot. But anyway, I don't know what else to tell you. They're out there. You'll see them. It really, I mean, it can debilitate them to a point of paralysis to where they're paraplegics. It's really, can be very severe. Okay, I have a hard time waiting on this hand rehab to go ahead and get into the brachial plexus, because we're going to learn about the radial nerve, the median nerve, and the ulnar nerve in the hand, and so we're going to kind of look at that today. Hand rehab, they're actually people who are certified in hand rehabilitation. I think a PTA can do that. It's quite a specialty. I happen to have a friend who's an OT, and most of the people who are hand therapists are OTs, but there's no reason why a PT can't do it. Don't let them push you out of it if you're interested in doing it. It's quite a specialty. Dr. Kelly, we've been really blessed to have Dr. Kelly in Fort Smith. I don't know if y'all have even heard of Dr. Kelly, but he's been practicing as long as I've been here. And he actually is probably one of the top hand surgeons in the United States. People come from all over the world to see him. And so he's just a real interesting guy. But anyway, he had a hand therapist that worked with him for years, Sharon, and I believe she's recently retired, but she was excellent. Now, she was an OT, I believe. I think Sharon might have been a PT. But anyway, hand rehab is something that you can specialize in and get certified in it. But if you're working anywhere, you're going to do hands. Any of these, the thing about going to work like at Sallisaw or Poto or Mena or some of these small hospitals, you see everything. You literally see everything. McAllister, because those people don't want to go to Tulsa to a hand specialist, or they're not willing to drive all the way to Fort Smith to have hand therapy. And so they want to come to Elite because they live in Tallahena, and Elite's a heck of a lot closer than if they have to go to Fort Smith. So we've worked over the years with Sharon. Like, she did most of the, she'd do all the splints and things like that, and then we would take and do the therapy. So we worked in conjunction with her, because there's a lot of people that aren't going to drive all the way back to Fort Smith, but they're willing to drive to Poto. But hand rehab is, you're going to see it in many, probably most of your outpatient clinics. I bet PT Inc. sees them regularly. These small outpatient clinics are ready to just see them. Hand anatomy. You've got your hand and wrist muscles and your wrist and finger extensors. And did y'all learn the names of all of these? You do realize that all of your muscles for your hand and on both sides is up here in your forearm. Y'all know that, right? And so extension goes to the lateral, actually it's the medial, because you're like this, right? And then flexion comes to the lateral. So you've got that muscle bulk, and they all kind of come into there together. And we can look at that a little more as we go. And then you have the thumb muscles, and they're kind of their own little thing. Most hand function is a tendon pulley system, and muscles are in the forearm. So that's where they are. So let's look at what the median, radial, and ulnar nerves do. The median nerve does this, and the second and third lumbricals. So pretty much this function right here is median nerve. That's what it does motor-wise. Dermatome-wise, the median nerve does this part of the hand, and goes right up to the front part of those fingers, okay? The thumb and everything, and half of the fourth finger, or the third finger, I guess is what we want to call that. We're going to do thumb 1, 2, 3, and 4, okay? So half of the fourth finger. And so that is the sensation of the median, and then this is the function of the median. It does the pinch. So that's the median nerve, okay? So thumb, flexion, opposition. What's opposition? This, right? This is opposition. Then you've got the lumbricals. That's the median nerve. And so that's pretty much what it does. The radial nerve does all extension, okay? And so it does extension, thumb extension, and abduction. So it does all the back. But sensory-wise, it only mimics the median nerve on the back. It does all the extension of all 5 fingers, but the sensation mimics the median nerves on the front through the third finger, the thumb and the fingers 1, 2, and half of the third. And the radial nerve, sensory-wise, is the thumb, and then the first 2 and half of the third finger. Okay, so that's the sensation part of it. But motor-wise, it does all of it. It does all extension. Okay? And it also does wrist extension, by the way. So finger extension, thumb extension, and wrist extension. The ulnar nerve does fingers 4 and 5 flexion. It does all finger abduction. So what is that? Those muscles. Interossei. Those are the interossei. So the ulnar nerve does interossei. It does the lumbricals on 4 and 5. And it does flexion on, I say 4 and 5. I'm going to mess y'all up. 3 and 4. And so he's calling them 4 and 5. What did my notes say? 4 and 5? Oh, my notes say what I usually say. Anyway, the last 2 fingers. Okay, but sensory-wise, the ulnar nerve does the front and the back of the little finger and half of the ring finger. So that's your ulnar nerve sensation. Function is just flexion of the last 2 fingers. It does all of abduction, the interossei or ulnar nerve, and it does the lumbricals on the last 2 fingers. Okay? So the reason why you got to get that down is there's going to be 100 questions on your licensure exam on it, because it's very important that you figure out what's going on. And so besides dermatomes, we know dermatome-wise, what is the thumb? C6. C6. C7, C8, T1. C8, T1 is also the ulnar nerve. The ulnar nerve is C8, T1, okay? If that helps. The median nerve is a bunch, and so is the radial. But your ulnar nerve is C8, T1. Okay, Ryan, tell me what the median nerve does and just what motor function it has.
The median nerve?
Uh-huh.
It's all the flexors of the wrist and fingers.
No. Not all the flexors. Just these. Okay? Remember, the flexion on these 2 is the ulnar. Okay, does that help? Okay. So, what is the sensation? What does the median nerve sensation, what is it? Sky?
It's from here over and half
The fourth
of this
one over. This one over. But yes, that's it. The front part of the hand over to the ring finger, half the ring finger. So that's the median nerve sensation. Function is the pinch. If that helps you do that. And it does the lumbricals on these 2 fingers. Okay? Kamichi, what's the function of the radial nerve in muscle?
These 2 fingers, the flexion and abduction and adduction.
You're thinking ulnar nerve.
Oh.
Anybody know what the radial nerve does? It does extension of everything. So it does extension of all the fingers, thumb, and the wrist. So just like that. So what is the sensory on it though? It mimics the median, except it's on the back of the hand. So it does the thumb, fingers 1, 2, and half the ring finger. So that's the radial sensation. Median sensation is the same thing on the front. Okay, so what's the ulnar nerve do motor-wise? It does opposition of. It actually doesn't do opposition, it does flexion. Because opposition would take in your thumb, and remember your thumb is median. So it does flexion of fingers 4 and 5, or the last 2 fingers. But sensation is the front and the back of the little finger and halfway through the ring finger. Okay? So y'all need to know that, because we're fixing to go over it with the brachial plexus. Okay, so a lot of diagnoses that you deal with hands. Trauma is probably the biggest thing. And the nice thing is they're fixing most nerve injuries now. They go in there and put them back together and they see quite a bit of return. It's just wonderful. Peripheral nerve injuries of any kind. A burn would be something that you deal with. What do you think physical therapists do mainly with burns now?
Make sure it doesn't lose motion from the scarring.
Right, they mainly work with maintaining range of motion, pretty much across the board is what they do. Normally they order the garments if they have like a lot of keloid scarring and it's a 3rd-degree scar. They're going to order those garments. The burn center there in Tulsa, they have a PT that's been there who actually graduated with Bill and she still works there. And so that's all she's ever done is burn therapy. But she does, mainly she does muscle strengthening with them, gets them up and walks them. But you have to realize that in that particular burn center, most of those people have over 60% of their body burned. She probably loses a large number of her patients. It would be a tough job to me. I mean, they're going to die. And so, but anyway, she does that if you're ever interested in doing burn therapy. But we used to do a lot of, we would do whirlpool with it, and then you'd have to get all the scabs off of it. It was horrible. It was a very difficult thing to do. But normally therapists don't do that anymore. It's a wound clinic type thing, and so people that just go in there, and usually they're burn techs, and they do all of that debridement themselves. But it's very tough. Burns are hard. Remember, if they're a 3rd-degree burn, is that painful? No, 3rd degree is not painful. 1st and 2nd degree are painful because it's burned away the sensory nerves. And so a 3rd-degree burn, those people do better, but if you don't keep them hydrated and stuff, they die on you, which is, what can happen. But you might see a burn out in the clinic, and especially a hand burn if people aren't willing to go all the way to Tulsa to go to the burn center. So you're going to have to do debridement on it, keep as much of the, it's not, we're going to do wound care here in next week or so, and we'll talk about the different names of stuff, but what happens in a burn is you have a buildup of yellow stuff, and sometimes and some skin sometimes has to be removed, and so you debride all of that down to the layer of skin that it is, and you do it every day. So they really live through some pain, a lot of pain burn patients have. And so, but you might end up having to do that. What if you got a burn just on the arm? Sometimes they'll come in, EOMC does lots of burns. A lot of people just maybe burn themselves in an area that's not so severe and has a bad burn on their back or something like that. So anyway, it is something that you might see in some of these small hospitals. Neurological, central nervous system residuals, that would be like a stroke patient. Spinal cord injuries, dealing with those type patients. And then carpal tunnel syndrome is one that's very common that you see. And so carpal tunnel syndrome, you usually deal with them after they've had surgery and that's been released. Okay, so for evaluation, you're going to look at range of motion, and when we get into, I have two little finger range of motion goniometers, and so we're going to go through that in the lab this afternoon. So you're going to do some range of motion. You're going to look at strength. So we'll look at grip strength, wrist muscles. Have y'all done wrist yet in muscle testing? Okay, so y'all can practice that. And then the pinch strength. There's actually a pinch strength dynamometer, but I don't have one. But there is one that you can get. If you're a hand therapist, you're going to look at that more so. And then you're going to evaluate sensation to see, and mainly I don't look at dermatomes as much as I look at radial, medial, or ulnar nerve issues in the hand. We just do that more, because normally it's a nerve injury. When would it be a dermatome issue? When would be the only time it'd just be a dermatome issue? With a spinal cord injury patient. Okay? But they're the same, right? It's still C6, C7, C8, T1. But you're going to look more at the ulnar nerve, median on the front, radial on the back. You're going to evaluate pain. And then their functional limitations. So you're going to look at fine motor versus gross motor control. Can they write? Can they still write with their hand? One of the things that's really nice is to make them pick up marbles. A normal hand can pick up 24 marbles and hold them in the hand. So that's actually part of therapy that I do with them. I hope I have marbles. I think I do. So anyway, you're going to look at some of that stuff. The very first thing that you do with hand therapy, and we talked about it, if they're inflamed and they come in more pain, what are you going to do with them?
Send them home.
Pain modalities and send them home. And then teach them how to do pain stuff at home. So, but you do need to desensitize before you do anything else with the hand. So if they have an area of a scar that is very sensitive, you've got to get rid of that. So you desensitize, and sometimes you spend 20 minutes doing it. So that's the first thing you look at is desensitization. Start with very soft cloth, massage the gentle strokes. Patient may need to do this himself because he cannot tolerate you doing it. Move to wash rag, hand in rice, hand in sand. Find objects in the rice, sand, and can, and also the edema control glove, the pressure garment you would need if you're doing quite a bit of hand therapy. They're pretty easy to get a hold of. I think you can order them probably off Amazon, would be my guess. Some of the treatments for inflammation, we're going to use what? Ice. Ice massage. Paraffin, we have a paraffin machine. So have y'all done paraffin yet? Okay. Well, we will do the paraffin. I'll check it. I'm hoping it's ready. Y'all haven't done paraffin with Bill? Okay, well, I better get all that information. We'll do paraffin this afternoon, might as well. Hot packs, you can use ultrasound at 3.3. Why? 3.3.
Superficial.
Yeah, so it's so superficial, so you're going to use the high. And usually, I rarely use it for pain. It's usually to get rid of inflammation. So you usually do the pulse. What has Bill told you heat modality versus to get rid of inflammation with ultrasound?
20%.
So did y'all do all pulsed ultrasound with Bill Carroll?
No, we did some thermal.
You did some thermal? Okay. He doesn't use thermal for anything. Did y'all realize? He doesn't do a lot of pain stuff, does he?
No.
So anyway, don't think that thermal is not good. It's good for pain. So make sure that, you just be aware of that. But it's also great, ultrasound's also great to decrease inflammation. It really is very successful on these small areas, the hands and the ankles and that kind of stuff. I'm not sure it does so much for the larger muscles, but, and then your E-stim, you can use TENS, interferential, just anything that's gonna decrease their pain. Mobilization of the fingers and wrists, we're gonna do this. Have you done some distraction and all that stuff? Where you just, it's very effective to just distract that joint. And it's really effective in a finger to just distract. It feels good. You're gonna enjoy doing it on each other. It feels good to do that. Doesn't that feel good?
It doesn't feel bad.
You don't like it?
It's not that I don't like
He doesn't feel anything. It's not positive or negative to him. But anyway, it just, doing that's just a way to feel better in your wrist. Just kind of to distract, that's a good way to start, and then to do your range of motion. So we're gonna do some mobilization. And then we'll do that in the lab. And then opposition, fine motor activities that we can look at. Supination, pronation of the wrist, flexion, extension of the wrist. Those are just range of motion. Reaching, grabbing, and release. So you want to do an object that's not heavy. I always start them on a very, very light grip ball. And I've got some, I just picked some up at the dollar store, so I'll show you what my new ones that I have. But even a foam ball is good. You mainly don't want strengthening initially. What do you want? Range of motion. Almost always range of motion. So, picking up smaller and smaller objects, you might do picking up cups, to doing pins, to marbles, to pennies. To pins, like a straight pin, or you could go to picking up safety pins. Eating, whether they need utensils or assistive devices for that. Writing, dressing activities, computer, typing. Playing the piano is great for these last two fingers. If they have a piano, it's really good to make them. Because what are the fingers that are the weakest on your hand? 4 and 5. Yeah. So they're really, if you're a piano player, you know that. So they really get weak, and they seem, it's harder to get them back. So playing the piano is good, and doing computer stuff. Grip activities, squeezing a ball of all consistencies, hand games. Have you ever done make the church and the steeple and all that kind of stuff? You can do the steeple and have them just push back and forth. Do all different fingers, because they're very weak. They can't even do opposition between the two fingers sometimes because they're so weak. And it's a coordinated movement. So you can do that one. Trying to think of different games. To do opposition, you can do putty and do all kinds of activities for them to be able to touch every finger with their thumb. So that's something they can shoot for. A lot of times they don't have that. You're always going to test their opposition at the beginning. That's this one. Finger extension on the table. A really good way to stretch out their hand is to put down flat and start them here, and then move up. Actually make them flatten their hand out on the table. A lot of times they can't do it. So it's a good way for them to do it. And then you can start working the wrist. That's a good way to work the wrist up too, where they can do weight bearing on it. Do not work with acute inflammation. If you overwork the hand, you may have to stop therapy for up to 2 to 3 weeks actually. And basically with Cheryl, we have not done strengthening yet, and I've been seeing her for 2 weeks. But when she went back to see Dr. Chang, he put her on steroids because he was so concerned. So that completely took that inflammation and swelling out of it. So that really helped us so that we could get all the range of motion. But she's just now getting to where she's not real sore in these muscles, but her hand's not hurting her anymore. So we're being successful, but I'm still not doing strengthening with her. And we might start this week, we'll see. So what is the most important thing that you should have learned from this lecture about hand rehab.
Don't work with kids.
Don't work it if it is inflamed, okay? Because if you do, you're just gonna make it worse. How long might you have to lay out? 2 to 3 weeks. I probably see them once a week just to check them, do pain modalities on them until it went away. Okay, I will see you in the lab, and we're going to do a